noted in the tail region of the pancreas. Previously, the
So remember,
operative bed.
History is relevant here, right? Patient's distal pancreas is taken out and spleen has been taken out.
At the
So when you
operative bed,
have extensive surgery with this kind of low density area with thickened with fat in the center, what can that be?
In the history of fever, it could be a collection, the collection in the post-operative bed.
Yeah. So, but more often than not, these, if you see this after an extensive surgery, these are typically, areas of fat infarction, right, or fat necrosis. Now, if they are in the omentum, they are called omental necrosis. If they are seen in regular peritoneal fat, that's. But yeah, can you be confident they are? Now, remember, it's low-grade fever. It's not spiking fever. So, and when you pulled up the old images, this distal pancreatectomy and splenectomy was a couple of years ago. And when you look at the old images, these look relatively stable. So we can discount them as post-operative changes. But what else is going on that you're worried about? Are the kidneys normal?
So kidneys are showing multifocal areas of decreased uptakes or ill-defined areas bilaterally.
Good, excellent. So now, what would your differentials be if you see something like that?
So most likely, it could be an infection.
So let's think about that. So if you think about multifocal infection, do you see a lot of stranding of the fat, perinephric fat?
Yes, sir. But here it is absent, so less likely to be an infection.
Good, excellent.
So renal infarction.
Yeah, so renal infarction, again, those are typically more wedge-shaped and, low density and multifocal infarcts like this, meaning the patient is showering multiple emboli. Do you see infarction of any other organ?
No other organ.
There's no bowel dilatation. You don't see a lot of atherosclerotic changes. Obviously, it's still in the difference, but go ahead. What else?
Due to splenectomy, that there could be secondary infection, low-grade infection.
Yeah, so infection is one, but like we said, right, there is not a lot of fat stranding, so that would be unlikely. Infarcts also possible, but less likely. Could this be lymphoma?
Yes, it could be.
Yeah, yes. So lymphoma is one possibility, and
but
then there is
lymph nodes. No other lymph nodes could be seen.
Yeah, there are no lymphadenopathy.
Exactly. That's less, again, makes that, although you can sometimes see that, but yeah, that's again less likely. So lymphoma is less of a possibility, but there is one other condition that you always think about when you see multifocal hypoattenuating renal lesions with no perinephric stranding that you should never forget.
Sir, IgG4 disease.
Exactly. So this is IgG4 disease, and this patient was put on steroids and did well. So just take home is multiple hypoattenuating lesions and CT in the kidneys. Do not forget IgG4. That's the most common manifestation of disease entity and most common way that this condition presents. And do not. We went back here. Give me 1 second. Anyway, we'll come back to that. So moving on to the next case, which is the last case, I think is, see if I can go back. For some reason I lost my, sorry about that, guys. I'm giving you the answers. Anyway, let me close this and we'll just go it. So the last case is a patient who has male patient with abdominal pain and microhematuria. So let me just bring up the quick CT. So who is taking this one?
So,
Suman, we will
yes,
take.
me. We will.
We will.
all of us.
You all can do it together. So
Yes.
here, this is the this is the these are the images. So
Sir,
The scalloping of the liver margins is seen, sir.
okay, but what else are you seeing here? So
Left
remember the
kidney.
history is the
Sir,
abdominal.
IHP, there is significant IHPRD noted with a lesion in the left
Left
kidney.
kidney, which is
Is there one lesion or so? How many lesions are there?
Multiple, sir, multiple.
So multiple lesions. Now this is not like the case I showed you earlier. These are not hypoattenuating. These are enhancing, right? Solid lesions.
Yes.
So multifocal lesions, enhancing lesions. What are some of the things that go through your mind?
syndromic.
Syndromic association.
Right. So which are some of the syndromes you'll think of?
VHL.
Tuberous sclerosis.
So tuberous sclerosis more likely to cause angiomyolipomas, right? But they are RCCs, you're right. So VHL would be one. And then a couple of other entities that can give rise to this pattern. And, we actually as radiologists are the first one to call attention to that, which is what happened in this case.
Birt-Hogg-Dubé syndrome.
Birt-Hogg-Dubé syndrome.
Right.
That has
So what else do you see in Birt-Hogg-Dubé syndrome?
Fibrofolliculomas on the face and chromophobe RCC.
Lung cysts.
What do you see in the lungs?
Lung cysts, which is having the basal predominance.
LAM.
No. So this is the same patient's chest.
Okay. The syndromic association.
Bizarre-shaped cyst with basal predominance are usually seen in Birt-Hogg-Dubé.
Exactly. So this is a patient who has multifocal solid lesions in the kidney with predominantly basal distribution of pulmonary cyst. And so this is a patient with Birt-Hogg-Dubé, and this actually was incidentally found, and we were the ones who suggested it. Now, can you tell me which are the common types of lesions you see in Birt-Hogg-Dubé in the kidney?
Oncocytomas mostly.
Is it oncocytoma or is it chromophobe RCC?
Okay. The chromophobe
RCC is most common.
Right. So there are 5 types of renal lesions that you have to keep in mind in Birt-Hogg-Dubé, but the two most common are the chromophobe RCCs and what we call as hybrid oncocytic chromophobe tumors. Those are the two common subtypes. Oncocytomas, believe it or not, is the third. It's less common than the hybrid oncocytic chromophobe type. And then the fourth and the fifth, which occasionally you can get, is clear cell and papillary RCCs as well. Although we don't typically, associate that, but they can also happen in the Birt-Hogg-Dubé patients. So that's what was here. And the take-home message here is, if you have multifocal renal masses in syndromic things, think about all the syndromes we talked about. And with Birt-Hogg-Dubé, as you said, there are basal distribution of pulmonary cyst along with multifocal solid renal masses. So I think we're on time and excellent, guys. You guys did a phenomenal job, and I don't know if there are any specific questions but from you guys who took the cases.
Sir, may I ask one question?
Sure.
Sir, in the last case of that IgG4 disease, sir, what was the reason for that splenectomy, sir?
The patient had a distal pancreatic neuroendocrine tumor. So when they have distal pancreatic lesions, they typically have to sacrifice the spleen. They can just excise the tumor. They have to take the spleen along with it. That's why the splenectomy was done.
Thank you, sir.
Excellent. Perfect. So thank you so much for everybody who attended, as well as the panelists. You guys were really amazing and did an excellent job. Thank you.
Thank you, sir.
Thank you, sir.
Thanks a lot for such a wonderful session, sir.
No worries. Thanks.
Thank you, sir. It was really amazing, and I think everyone participated also really well.
Thank you, sir.
Yeah, no, thank you. Take care.
Thank you, all of you, for being such an amazing volunteers.
Thank you, ma'am.
An amazing session. I
Thank you.
think so there are few questions in Q&A, but I think you have already covered those. I think he already left also. Okay, fine. So take care, guys. Thank you so much. Have a great weekend remaining on.